Welcome to the symposium on MASTER DAPT trial, dual antiplatelet therapy after coronary stenting in high bleeding risk patients, sponsored by Terumo Corporations. The objectives of these sessions are to learn about MASTER DAPT clinical study design, to gain new insights into MASTER DAPT clinical outcomes for high bleeding risk patients, and to learn how MASTER DAPT results bridge the current knowledge gap on DAPT durations in high bleeding risk patients. My name is Hui Chim Tan, and with me in the studios are Dr. Jack Tan and Imran Said Saqib. In this symposium, we have also international speakers in Dr. Fazila Malik from Bangladesh, Dr. Ang Yong Kun from South Korea, and Dr. Scott Harding from New Zealand to join us remotely. These sessions will not have served its purpose of being an educational event without you, the audience, participating in it. I'd like to welcome all of you who are logged on to type your questions and comments onto the chat post. We will try to answer all your queries in as much as we can. And today, Dr. Imran Said Saqib will also be your chat master, actively engaging with you online. For selected questions of interest, Imran will also raise it for discussions with the studio and remote experts. I would now like to begin by inviting Dr. Fazila Malik to speak on the MASTER DAPT trial.
Friends and colleagues, it's indeed a great honor for me to be presenting the results of the MASTER DAPT trial today. Now, the MASTER DAPT trial was undertaken in a group of high bleeding risk patients who had undergone PCI. And this study was aimed to find out whether abbreviated DAPT after stent implantation would mitigate bleeding risks for these patients without in any way compromising safety or increasing their ischemic risk. This was a global study which was undertaken in 140 centers spanning 4 continents. And in this study, the high bleeding risk patients were treated exclusively with the UltiMaster stent. There was no restriction based on any clinical presentation or PCI complexity. And after 1 to 1.5 months, the patients were randomized. Now, only if the patients were free from any ischemic complications, they were not having any active bleeding, and there was no further revascularization plan for them, the patients were randomized either to the abbreviated DAPT group or the standard DAPT. But in the abbreviated DAPT group, there was immediate discontinuation of DAPT, and the patient was followed by a single antiplatelet for 11 months, or for 5 months if the patient was already on an oral anticoagulant. On the other hand, if the patient was on the standard DAPT arm, then the patient would receive DAPT for 2 to 5 months, depending on whether the patient was on or without an oral anticoagulant. And after that, the single antiplatelet was continued for 11 months. So the patients were deemed as high bleeding risk if they had one of the following criteria, or if their precise DAPT score was more than 25. And the patients were excluded from the trial if they had been ever treated with a bioabsorbable scaffold, if the patient had been treated with any other stent other than UltiMaster, or the patient was being treated for in-stent restenosis or stent thrombosis. And the UltiMaster stent was chosen here because this stent already had a CE mark for 1 month DAPT. So this study, interestingly, had 3 co-primary endpoints, and these points were tested in a hierarchical order. The first point to be tested was the net adverse clinical events, or NAES, which was a net composite of all-cause death, MI, stroke, and major bleeding defined as BARC 3 or BARC 5. After this came major adverse cardiac and cerebral events, the composite of all-cause death, MI, and stroke. And lastly was major or clinically relevant non-major bleeding, the composite of BARC type 2, 3, or 5 bleeding. Now, the first 2 primary endpoints were tested on a non-inferiority basis in the per population protocol, and only when the non-inferiority for these two endpoints was met, then the third endpoint was addressed, and this was tested on a superiority basis on the intention to treat population. So if you look at the randomization, a total of 4,579 subjects were randomized, and they were divided into the abbreviated DAPT or the standard DAPT group, and the outcome was studied up to 1 year. If you look at the baseline characteristics, all these patients had more than 2 or at least 2 high bleeding risk criteria. Most of them were elderly. A third of them were suffering from diabetes mellitus. Atrial fibrillation was present in another third of these patients. These patients were on oral anticoagulants. 35% were on oral anticoagulants. And if you look at the clinical scenario, 50% had chronic coronary syndrome, and the other 50% presented with acute coronary syndrome, which included ST segment elevation, myocardial infarction. Regarding the procedural characteristics, the vast majority of the cases were done through the radial route. Multivessel intervention was undertaken in 25% of the patients. Left main was done in 5% of the patients. Number of stents used per person was 1.7. Total stent length was around 39 millimeters. Overlapping stenting was done in around 21% of the cases. Now, if we look at the DAPT regimen, the median DAPT duration time in the abbreviated DAPT group, it was only 34 days, whereas in the prolonged DAPT, it was, or the standard DAPT, it was 193 days. And once the patient went to a single antiplatelet, it was either aspirin or a P2Y12 inhibitor, depending on the investigator's choice. So if we look at the results, what do we see? Regarding MACE, we see that in the abbreviated DAPT group, it was 7.5%, and in the standard DAPT group, it was 7.7%, and this gave a non-inferiority margin for this endpoint. And then if you look at the MACE, we find that for the standard DAPT, it was 5.9%, and for the abbreviated DAPT, it was 6.1%. And this also gave the patient a non-inferiority margin for this analysis as well. And ultimately, we come to the third, which was the superiority study, and we found that here there was really significant difference. In the abbreviated DAPT, it was 6.5%. In the standard DAPT, it was 9.54%. So there was a superiority benefit when the DAPT was abbreviated. Significant findings. Now, if you look at the secondary endpoints, there was not much difference between the abbreviated DAPT and the standard DAPT group, but there was some numerical difference, but there was significant difference in the BARC2 type of bleeding, which was significantly higher in the standard DAPT group. Like all studies, this study did have some limitations, one being that this was an open label study. The next was that the DAPT duration in both arms was longer than what is currently recommended for patients on oral anticoagulants. And the study was not designed to assess the role or type of single antiplatelet after dual antiplatelet discontinuation. And one very important feature that we need to understand is that these results may not apply to patients who are not being treated with biodegradable polymer sirolimus eluting stents. But this study did conclusively show that in patients at high bleeding risk who had undergone implantation of a biodegradable polymer ultimaster sirolimus eluting stent, the discontinuation of dual antiplatelet at a median of 34 days compared with continuation of treatment for a median of 193 days after PCI was non-inferior for the incidence of net adverse clinical events, non-inferior for the incidence of major adverse cardiac or cerebral events, and was associated with a lower incidence of major or clinically relevant non-major bleeding. And the findings of these studies were recently published in the New England Journal of Medicine simultaneously. And I truly believe that this study will definitely make an impact on how we treat our high bleeding risk patients who undergo PCI in the future. Thank you.
Thank you very much, Fazila, for taking us through the MASTER DAPT trial, probably one of the most important trials regarding shortened duration of dual antiplatelet therapy in PCI in recent times. So, Scott, I want to start off by asking you, this study design has got 3 endpoints, 2 of which was non-inferior, 1 was superiority. Take us to what is the significance of such a design?
Yeah, first of all, I'd say it's a pleasure to be here, and I do think this is a really important, major study. Look, it is a complex design with 3 co-primary endpoints, 2 of which were non-inferiority. So the first was a NACE, which is a combined ischemic bleeding endpoint. The second was MACE, which was essentially a ischemic endpoint, and then the third was bleeding, which was the superiority endpoint. I think the purpose of having the first 2 as non-inferiority endpoints is if they were superiority endpoints and superiority wasn't met, you could then not do a further analysis. So it may be that those had a strong trend towards a benefit, and then you wouldn't be able to analyse to see whether there was a reduction in bleeding. So that is the logic behind the way this was constructed.
Thanks. So is this a practice-changing trial, Scott? And do you think a transition to a change is easy in this study?
I believe so. The major difference in this trial is it's the first large 4,500 patients randomized controlled trial comparing short DAPT to longer DAPT. A lot of the trials studies that have gone beforehand have compared different devices, for example, with short DAPT, drug-eluting stents with bare metal stents using short DAPT. They haven't compared the duration of DAPT, or they have been retrospective single-arm studies comparing to historical controls or an optimal performance criteria. So really, this is a groundbreaking trial. And what it does is give us some confidence. We didn't see an increase in ischemic events, and we saw a substantial decrease in bleeding events. And certainly for patients with stable coronary disease, this gives me a lot of confidence that in high bleeding risk patients, I can use 1 month of DAPT with no ischemic penalty. And we'll talk a little bit about the role in ACS and the controversy that I think going forward.
Well, since you talk about ACS, so 50% of the patients' populations have got acute coronary syndromes. And so you are thinking of giving them abbreviated DAPT for a month. And so how do you reconcile with the STOP DAPT ACS trial, which suggests a high incidence of ischemic and complications for people with shortened DAPT then?
Yeah. Obviously, that's a really important finding. The STOP DAPT ACS trial was a different trial. It was a different trial design. So first of all, it was 100% ACS patients. Whilst there was a significant proportion in MASTER DAPT, 50%, it wasn't 100%. Second of all, there was no high bleeding risk criteria for recruitment into STOP DAPT ACS, so that they weren't. While we could have included some high-risk bleeding patients, it wasn't a prerequisite for going in. Secondly, that the duration of treatment was different. So once the short DAPT group in STOP DAPT ACS was 1 month of DAPT, followed by Clopidogrel, whereas in MASTER DAPT, you could choose your single antiplatelet agents. Admittedly, the majority of people did have Clopidogrel, but you could have aspirin, you could have ticagrelor. And so they're quite different. I think certainly when we saw and stopped at ACS, that there was a significant increase in MI, almost a doubling in MI. And if we look carefully at MASTER DAPT, there was no increase in ischemic events. However, there was a numerical increase in myocardial infarction and stent thrombosis, but this was balanced by a reduction in stroke. So I think they're very different trials. I think for me, there's still some caution around ACS, and we don't know what the optimal duration is of DAPT and ACS. And if we're going to shorten it, it should be 1 month or 3 months, but I think we're going to discuss that later.
Certainly, two different trials, but begs certain answers as well from the trials. Dr. Ang, one of the group of patients who are at high bleeding risk in this study were the patients on oral anticoagulant. Up to 35% of them were on oral anticoagulant, and they seem to the worst group is the group that were on standard duration on oral anticoagulant. What does that tell you?
So I think that one of the major limitations in MASTER DAPT trial is the relatively long duration of triple therapy in the standard antiplatelet regimen groups. So probably this can maybe some impact on some results. And also the high proportion of warfarin use would also have some impact in the current study result. So I think there's some long duration of triple therapy, especially in the standard antiplatelet regimen group, especially in oral anticoagulant, versus 35% of patients. So I think it's maybe contribute to the higher risk of bleeding.
Yeah, it just reinforced my personal belief that a prolonged duration of triple antithrombotic therapy after PCI is a real predictor of bleeding for patients at high bleeding risk. 1/3 of the patients on oral anticoagulants were using warfarin. Did you think that the use of warfarin vis-a-vis NOAC would have been different in terms of its results?
Yeah, I also think so, because the 1/3 of warfarin use could be also result in the higher risk of bleeding.
Scott, one of the favorite questions for this MASTER DAPT trial is why is there no reduction in severe or fatal bleeding in BART 3 or 5 incidents? We only see the reduction in bleeding in only the BART 2.
Yeah, that was a surprising result. I think most of us expected to see a difference in, BART or severe bleeding BART 3 to 5. I think one of the issues is that actually the duration of DAPT in the standard arm, it wasn't 12 months. It was significantly short, around 6 months. So actually that could have contributed to why we didn't see as much bleeding as we would have expected. But I think, if we look at the trials overall and totality of the trials, we know that shorter DAPT reduces bleeding. I don't think there's any doubt about that. It reduces minor bleeding, but also reduces major bleeding. It wasn't quite shown out in this trial. And I guess, the smaller the difference in duration of DAPT, the less bleeding difference you're going to see. And we saw that in the oral anticoagulation when the difference in DAPT duration was even smaller. And actually then we saw virtually, a non-significant difference in bleeding rates.
Thank you very much, Scott. We're going to come back to you again and Dr. Ang, but right now I'd like to go to Dr. Ang to talk on the interesting high bleeding risk patients, and then we'll come back to you again. Dr. Ang.
Okay, I'm Young Nam from Korea, who works in Jeonnam National University Hospital. My title is High Bleeding Risk Case Study and DAPT Best Practice. I have nothing to be disclosed. So this is New York criteria for high bleeding risk. High bleeding risk is defined as PROX3 or 5 bleeding risk of more than 4% at 1 year, and the risk of intracranial hemorrhage of more than 1% at 1 year. Actually, this is the factors associated with an increased bleeding risk after percutaneous coronary intervention are aging, comorbidity, and the laboratory findings, and the CNS problems, and the bleeding history, and the iatrogenic condition. So this is the 20 clinical criteria were identified as major or minor by consensus, supported by published evidence. Patients are considered to be at high bleeding risk if at least one major or two minor criteria are met. So this is the determinants of antithrombotic treatment in the coronary artery disease, the intrinsic in blue and extrinsic in yellow. Variables influence the choice, dosing, and duration of antithrombotic treatment. So this is the case. So 48 female patients who suffered from chest pain, remote onset 2 months ago, and the recent onset 5 days ago. She has hypertension with 40 years on medication. The ECG on admission demonstrates that normal size rhythm with some anterolateral ischemia and some TIV inversion in inferior wrist. So chest X-ray demonstrates the scoliosis, osteopenia, and the infiltration in right lower lung field, however, no cardiomegaly. This is the laboratory findings. Some decreased hemoglobin level, however, others are normal. Troponin T is slightly elevated to 0.067 nanogram per milliliter, and then also slightly elevation of CKMB, 5.10 nanogram per milliliter. So our diagnosis is non-ST elevation of acute coronary syndrome at high risk condition and hypertension. Our planning is overly invasive PCI, 300 milligram loading dose aspirin, 600 milligram loading dose Clopidogrel. So this is a coronary angiogram. It's an insignificant stenosis in right coronary artery, and also diffuse stenosis up to 8% in distal circumflex artery, and then tandem region diffuse stenosis up to 8% in proximal mid LAD. So we had SPB 3.606 French guiding catheter was used, and the pre-dilation with 2.5 by 15 millimeter balloon for LAD. And we put the Resolute Onyx stent 3.05, 34 millimeter. And then we post dilatation with NC 3.05, 15 millimeter balloon. And this is the result for the LAD. And also the pre-dilation with 2.5 by 15 millimeter balloon for circumflex artery. And then Resolute Onyx 2.5 by 38 millimeter in distal part, and the Resolute Onyx 3.0 by 15 millimeter at proximal part. Post dilation with NC 3.0 by 15 millimeter balloon, and then this is the final result, the after PCI. So 2D echocardiography demonstrate the severe, the LA territory hypokinesia, and the global ejection fraction is 55%. However, the patient after PCI, she very suffered from severe epigastric soreness, and then we performed in the urgent the esophageal-gastroduodenoscopy, and the esophageal-gastroduodenoscopy demonstrated that the huge and deep ulcerative region in antrum lower curvature And then pathologic diagnosis is adenocarcinoma, diffuse type, poorly differentiated. So staging workup with CT demonstrate no evidence of distant metastasis. So this is a criteria for high bleeding risk, as I mentioned before. And this patient had major criteria, active malignancy within the past 12 months, and possibly non-deplorable major surgery on DAPT, and also minor criteria, age more than 75 years old. What would be the optimal DAPT duration strategy for the patient? So actually you are familiar with the MASTER DAPT trial. This is also reader split trial, and you in a high bleeding risk PCI population in the biofreedom DCS versus bare metal stent 1-to-1 randomization, DAPT mandated for 1 month only, followed by long-term SAPT. So polymer-free bioluminescence coated stent was superior to bare metal stent in a high bleeding risk patient when used with 1 month course of DAPT in a primary safety endpoint and the primary efficacy endpoint. This is ONYX 1 trial. It's a result of ONYX. And then also biofreedom DCS with 1 month DAPT, 1-to-1 randomization in the primary safety endpoint, secondary efficacy endpoint. This polymer-based jotalimos eluting stent was not inferior to use of polymer-free drug coating stent with 1 month DAPT. So recent ESC guidelines demonstrate that in patients at very high risk of bleeding, defined as recent bleeding episode in the past months or planned, not deplorable surgery in the near future, 1 month of aspirin and clopidogrel should be considered. So this is the plan for DAPT strategy in the case. The patient planned PCI for elevated circumflex with DS due to non-elevation myocardial infarction. We used the 300 mg loading dose of aspirin, 100 mg maintain, and the 600 mg loading dose of clopidogrel, 75 mg maintenance. So 1 month DAPT. And then we proceeded with the subtotal gastrectomy with 5 days continuation of clopidogrel, and then aspirin 100 mg maintenance SAPT. Thank you very much for your attention.
Thank you very much, Dr. Ang. That was a clinically challenging case. I want to ask Jack. So this is an elderly lady coming with anemia and then has got acute coronary syndromes of STEMI, and he's got obviously a severe double vessel coronary artery disease here. Now, say if you don't know about this CA stomach issue from the very outset with this sort of anatomy and this sort of clinical profile, would you have given an abbreviated DAPT in the light of a MASTER DAPT trial? Or you would have continued for a longer duration given that she has ACS and the ischemic burden here is high?
So thanks, Jim. That's a fantastic case presented by Dr. Ang. I really like this case, which is classic of a lot of the older age group patients that we see. I think, firstly, not all ACS cases are the same. It's quite a heterogeneous group. I think there are some where the bleeding risk is even higher. And clearly, this case is in the high ARC criteria. It has actually 3 major, including a HB of less than 11 grams. And I will make a distinction between age above 75 and age close to 85. That's even a higher bleeding risk primer. I think I'll look at 2 things. I'll look at the coronary intervention that I've done, how many stents I did, whether it was complex. In this case, the lady had a pretty, I would say, relatively straightforward PCI, although with 3 stents, with good size stents and probably optimized extremely well. I would think I would be actually very comfortable to have an abbreviated regime based on the MASTER DAPT type of scenario in this particular lady. And it is proven that they do bleed if you try to drag the DAPT up to 1 year. Back to you, Hui-Jin.
Yeah, so Imran, do you agree with this stenting these 2 arteries and then going for a surgery? Or would you have considered a medical therapy for this patient while telling the surgeons that he's at a higher risk of perioperative cardiac ischemia? I mean, given the fact that now you have patients who are just stented and is on DAPT going for surgery, how are you going to talk to the patients and the surgeons here?
Thank you. So looking at the scenario and the diagnosis with a possible malignancy, this will need a good discussion with the surgeon, with the cardiologist and the patient itself. And guidelines still say that you have to wait for 6 months after PCI with the DES, irrespective of the diagnosis, either ACS or stable coronary artery disease. And if possible, if the surgery can be deferred, wait for 6 months. But in this case, I presume it was fairly urgent kind of scenario where you can't wait 6 months. So minimum possible duration based on ESC is now 1 month. If I'm the operator, after discussion, I probably propose 6 weeks to 3 months, somewhere in between. Longer the better. I will at least 6 weeks, because we know that the risk of getting a stent thrombosis or MACE is high in the first 1 month after PCI.
So you would defer the surgery to a longer period of time?
If possible, probably more than 4 weeks, yep.
So Jack, I was going to ask you, so would you tell the surgeons to operate with aspirin on board? And would you restart the patients on DAPT after the gastric operation?
That's a great question, Wei Chim. I think if the surgeons are comfortable operating on at least one antiplatelet, I can sleep well at night. So I would say, please, if you can, operate on at least one antiplatelet. And I must say, our surgical colleagues are very afraid of P2Y12. They're actually quite comfortable in operating on aspirin, as in this case. So that would be my preference. I think it's safer for the stents. I would not restart the DAPT after surgery, actually. I think if it's past 1 month, I'm quite comfortable to just carry on with a single antiplatelet for this particular patient.
So what stent would you choose then?
I think any of the stents that's been validated for shortened abbreviated depth, including the AICT-AsiaPCR stent, is a good choice in this case.
Thank you very much. So I'd like to invite Scott Harding now to really take us through some of the trials on high bleeding risk patients, and then we can learn a lot more from him.
I'm Scott Harding from Wellington Hospital, New Zealand, and my task is to talk about high bleeding risk trials update. These are my disclosures. So when we look at the short DAPT in high bleeding risk patients undergoing PCI, there's a large number of trials, and they're very different in respect to many design elements. And this creates confusion. So we have trials comparing different devices for short DAPT in high bleeding risk patients in both arms. We have trials comparing different DAPT durations in high bleeding risk patients. We have single-arm trials in high bleeding risk patients comparing their results to historical controls or objective performance goals. We have short DAPT randomized controlled trials or single-arm studies not specifically in high bleeding risk patients, which have subsequently performed a subgroup analysis in high bleeding risk patients. There are also many other features that are different in these studies. They have different criteria for defining high bleeding risk, different populations. Some have included ACS, some haven't. Some trials have excluded patients on oral anticoagulants. Some people have trials have excluded patients with complex PCI. There are different durations of DAPT in these studies. Short DAPT might be 1 month, 3 months. There are different types of monotherapy following the DAPT. There are different primary outcome measures, and there are different trial durations. And all of this makes all this quite difficult to feasibly understand these studies. This is just an example. I'm not expecting you to read this, but of looking at different trials and the different criteria they've used to define high bleeding risk. So you have some trials using a single criteria, such as senior or COBRA reduce, and other studies such as MASTER DAPT using 10 different criteria. As you know, the ARC came up with a unified high bleeding risk definition, which they published in 2019. These studies I'm going to be talking about were designed and performed prior to publication of these criteria, and I think these will be very useful going forward. So if we look at the studies that have been performed to date, a lot of the early studies looked at compared different devices with short DAPT. So initially, they're comparing drug-coated stents, drug-eluting stents, or drug-coated balloons with bare metal stents. And more recently, Onyx One compared two different drug-eluting stents. And essentially, what we found from these trials is that a bare metal stent was inferior to either drug-eluting stents or a drug-coated balloon. And that there was no difference in the Resolute Onyx between the studies. Now, what these trials didn't tell us is whether 1 month was better than longer duration, but they did give us some insight into the potential safety of short duration DAPT. We have a lot of single arm studies that have been really subsequently performed to assess the safety or potential safety of short-term DAPT, that's 1 to 3 months, in a variety of devices. Now, I'm not going to go into the detail of each one of these because we just don't have the time. But suffice it to say, what these studies have told us or given us an insight to is that using short DAPT in these devices may be safe and does appear to reduce bleeding compared to historical controls. I'm going to talk a little bit about Twilight because I think it's an important study. This was not a study in high bleeding risk patients. It was a study in high risk patients. A lot of them had ACS or other high risk features for ischemia. And there were some patients with high bleeding risk features, but it was not specifically a study in high bleeding risk patients. But I think it was important because this assessed 3 months of that followed by ticagrelor monotherapy versus 12 months of DAPT. And what this showed is that there was a substantial risk in risk reduction in bleeding 2, 3, or 5 with short DAPT followed by ticagrelor monotherapy. And that included the more serious bleeding, BARC 3 or 5. Importantly, there was no signal for increase in ischemic events. And so this was a landmark trial for those reasons. STOP DAPT 2 was not a trial that specifically looked at the high bleeding risk patients, but subsequently a subgroup analysis was performed looking at the high bleeding risk group. And what that showed is that in the study, if we looked at the high bleeding risk patients, there was a significant reduction in the net primary endpoint, which was a combination of bleeding and ischemic events with 1 month of DAPT compared to 12 months of DAPT. And again, there was no increase in ischemic events with a shorter duration DAPT in the high bleeding risk group, or for that matter, the other non-high risk bleeding group. So coming on to MASTER DAPT, this has been presented in detail, so I'm not going to talk much about this at all. But what we showed is that with a short DAPT of 1 month compared to a prolonged DAPT, that we had, it was non-inferior for the net adverse outcome, it was non-inferior for ischemic outcomes, and it showed a reduction or associated with a reduction in bleeding events for short DAPT. At the ESC, STOP DAPT 2 ACS was also presented, and there's been a lot of discussion about this and the differences between this and MASTER DAPT. So this study looked at patients with ACS undergoing PCI and randomized into either short DAPT 1 month or prolonged DAPT 1 year. And that DAPT was with aspirin and clopidogrel, and following short DAPT, the monotherapy was with clopidogrel. And what they showed is that there was short DAPT was non-inferior for the primary outcome, which was a composite of ischemic and bleeding events. But somewhat worryingly, there was a strong trend for an increase in ischemic events with the short DAPT. And when that was broken down, there was actually a significant increase in MI in the short DAPT group. Now, obviously, this is quite different to the findings of MASTER DAPT, and there's been a lot of discussion about why that may be. There were different trial designs. For example, This was an ACS population alone, whereas MASTER DAPT was a mixed population. In STOP DAPT2 ACS, patients weren't allowed to be on oral anticoagulants, whereas obviously about a third of patients in MASTER DAPT were on oral anticoagulants. That the monotherapy was different after the period of dual antiplatelet therapy, so it was only allowed to be Clopidogrel in STOP DAPT ACS. So there are a number of differences between the trial. And again, the platforms used were also different, and these may explain the differences between the studies. So what do we know? So we know that there's no role for bare metal stents in high bleeding risk patients, and essentially they've been consigned to history. In high bleeding risk patients with stable coronary artery disease, using 1 month of that reduces significant bleeding and appears to be safe. But we're uncertain about several things. We don't know what the optimal duration of DAPT in high bleeding risk patients is with in ACS patients. And we don't know what the best antiplatelet therapy for monotherapy following DAPT is. Is it aspirin? Probably not. Clopidogrel is widely used, but there's a variable patient response. And is this playing some of the role in higher risk monotherapy after ACS? Ticagrelor may be a good option, and prasugrel, again, may be a good option, but we're limiting data. I have limited data on this at the present point in time. And again, there's a lot of debate about the minor differences in the stents currently available, and whether these play a role in regarding safety in short DAPT duration. That's unknown. So still some important questions to answer, but I think that I've tried to give you a summary of the trials, a lot of data to try and suggest, but thank you.
Thank you very much, Scott. That was a very comprehensive overview. I want to ask Fazila, given this heterogeneity of clinical trials and with so many different populations, groups involved here, how do we integrate all this data? In other words, how do you perform bleeding risk stratifications for patients? And if so, what do you use precise DAPT score? Do you use equity, or do you use crusade score in the way to guide your treatment durations for patients with high bleeding risk? Fazila? Yeah.
Exactly. I mean, there is such a wealth of information that we have about high bleeding risk and how to tackle these patients when they undergo a PCI, and it can sometimes be very confusing. But one thing we also need to understand is that the high bleeding risk criteria has been different in different trials. And that's where we need a consensus or something that we all agree upon, not only trialists, but we clinicians who see our patients on a day-to-day basis. And I feel that the Academic Research Consortium's high bleeding risk criteria and their definition fills the bill. And honestly, I really don't use any of those scores. And I don't think any clinician usually does use the scores on a day-to-day basis. So I think the HPR criteria by Academic Research Consortium, that fills the bill.
Thank you, Fazila. Imran, I understand there's a questions from the audience. Can you tell us?
Yeah, there are a few questions here. Maybe Mr. Islam. So in the setting of STEMI, how often operators follow the current guidelines strategy to deal HBR cases?
You mean the STEMI durations of the APT?
The HBR category, yes.
So Jack, somebody with high bleeding risk and STEMI, what do you do?
So this has been brought again and again, and I love the talk by Scott Harding. There's a lot of confusion now because the high bleeding risk trials are confused with the ACS trials. So I think if you look purely at the high bleeding risk trial, I personally feel that bleeding risk trumps ischemic risk in that subgroup. So in a STEMI subgroup, it's true that you want to treat the STEMI, get them reperfused, get them at least, in my preference, 3 months of DAPT, then quickly drop the aspirin and truncate down. I like the Twilight regime published by Roxana. I think that's a reasonable regime to consider. In the even higher bleeding risk group, I would favor switching down to Clopidogrel in the subgroup. So again, I think you have to individualize to that patient. But harking back a little bit more, in the old trials for ACS, post-stenting, the curve continues to separate with a use of DAPT versus single up to 12 months. That's why the guidelines advocate 12 months. But the biggest bang for the buck is in the first 3 months for this separation.
Yeah, it is true. So I think the bleeding risk actually, in the beginning after PCI, it is the ischemic risk that's higher, but over time, the bleeding risk actually overtakes. I want to ask Dr. Ang, so we know that Clopidogrel is the commonest used antiplatelet therapy in the MASTER DAPT trial. And also in the Korea, we have this host exam trial that tells us Clopidogrel is a superior monotherapy compared to aspirin. So is Clopidogrel your preferred sole antiplatelet therapy after PCI in the high bleeding risk patients?
So I think it's, as you mentioned, that host exam trial revealed that Clopidogrel monotherapy is superior to aspirin monotherapy. So in Korea, so I think it's a dual antiplatelet therapy after the monotherapy. I think it's the Korean some interventionists prefer to use in the Clopidogrel. So I think it's especially in the high bleeding risk patient. So Clopidogrel is the good option to maintain for the monotherapy.
Very interesting. So Clopidogrel is the preferred monotherapy. Scott, what do you do in New Zealand now that you have a Twilight trial to tell us that perhaps ticagrelor is a good monotherapy?
Yeah, I think it's a very interesting thing. I have to say at the moment, we're still using Clopidogrel, but when we use Clopidogrel as a monotherapy, I like to try and gene test people, make sure they're a responder, because I think that is an issue. So we know, for example, in the Indigenous population in New Zealand, about 50% of people, have Clopidogrel resistance. So I think that is an issue. We know that ticagrelor is more potent than Clopidogrel in terms of producing bleeding. So it's a bit of an unknown at the moment. And I don't think we know the optimum drug treatment, but I don't think it's aspirin. At the moment, we're using Clopidogrel. My personal view is that maybe that will go to low dose ticagrelor, rather 60 milligrams than 90, but we need a trial to show us that.
Yeah. Imran?
So if we have a scenario where we have a temporary need for triple therapy like DVT or pulmonary embolism, so after completion of NOAC, 3 months, 6 months, will you guys switch back to the DAPT for 1 year in the setting of ACS-PCI?
So Jack, coming back to you again. So somebody with a high bleeding risk and has got ACS and has got a DVT. So this question here of a triple antithrombotic therapy.
So triple antithrombotic therapy, whether it's with NOAC or with warfarin, is a bad idea. So whenever you need to switch to triple, consider shortening the DAPT, particularly dropping the aspirin to a PTY12 inhibitor. I think you need to look at the indication of whether this DVT is with PE, is it provoked, whether there's a need for lifelong oral anticoagulants. If there is, then you carry on with just a PTY inhibitor with adjusted dose NOAC. That would be my choice. If you do have to then drop the NOAC, I wouldn't necessarily go back to a DAPT regime in a high bleeding risk group. I'll just continue with a single antiplatelet agent.
What about OACC as a single antithrombotic therapy?
So OACC, you can transit if there's indication like whether it's due to a DVT-PE or AF indication. I would say that after 6 to preferably 12 months after, OACC alone without any antiplatelet agent is validated for use and endorsed by the guidelines.
The OACC alone trial from Japan does support that. Do you have another question, Imran, from the audience?
Something similar, recent stroke and followed by PCI. So how long will you give a DAPT for these kind of ischemic strokes?
So for Zilla, you have a stroke patients and then now coming with ACS and then you did a PCI. So
ACS, yep.
ACS, stroke, what are you going to do? Do you give?
So first question would be what kind of stroke? Is it a hemorrhagic stroke or is it an infarct? If it's a hemorrhagic stroke, then we are in a bit of a trouble, right? And I would opt for a single antiplatelet maybe if it's a very large stroke. But if it's an infarct stroke, then it really doesn't make much of a difference.
Good. Scott, I want to ask you again, MASTER DAPT didn't really take into considerations the lesion complexity as well. When you give somebody dual antiplatelet therapy for a month, it is quite different between a single vessel and a triple vessel or left main or bifurcation complex. And so is lesion complexity a factor as well in your considerations?
So MASTER DAPT was an all-comers trial. So it did include some patients with complex lesions, but also it included many patients with non-complex lesions. So can we say for sure that there isn't a difference between complex lesions and non-complex lesions? No, we can't. We have a lot of evidence from other studies that complex lesions, for example, two-stent bifurcation, are more likely to have stent thrombosis than non-complex lesions. So we know from the data to date that it's relatively safe. Is there a small difference? Well, there could be in the trials to date, wouldn't be able to detect that. My take on this is it's a factor to consider. If I'm going to do complex lesion in a high bleeding risk patient and I want to reduce DAPT duration, then I think intravascular imaging is essential to make sure that we do it well to reduce the risk of stent thrombosis.
Completely agree with you. I think there has been a wonderful discussions among all of us here. And let me just wrap it up with some concluding take-home pointers. I think as far as MASTER DAPT is concerned, I think 1 month DAPT after implantation of UltiMaster DES is non-inferior to 3 months or more of a standard antiplatelet therapy in NACE as well as MACI. The abbreviated antiplatelet therapy definitely reduced major or clinically relevant non-major bleeding. And the results, I think, probably and reasonably apply only to the use of UltiMaster stents in high bleeding risk patients and may not necessarily extend to other second-generation stents or other patient subgroups with other stents. So with that, I'd like to thank all of you for participating in this symposium. I'd also like to thank the audience, both here in person as well as in the comfort of your own place for joining in this symposium. So thank you, and stay with us some more. We do have an exciting program of complications, which is the ever favorite in every meeting. Thank you very much.